Thank you. This session is session 5, low acuity, high prevalence paediatric referrals with Dr. Austen Erasmus. So thank you to Armchair Medical for sponsoring this session. Pop over to the sponsors and look through the individual pages. Armchair Medical Go are new apps that allow GPs to watch or listen to hundreds of medical conferences while commuting or exercising. And if you're in this paediatric session, you may find the paediatric emergency medicine conferences on the apps interesting as well. And they're offering a 2-week trial to all delegates. Scan the code on the slide. Or visit armchairmedicalt.tv/trial, or speak to them at the trade area during the break to start your free trial. Now, please take note of the health pathways relevant to this session. If you have a question for Dr. Erasmus, please type your question in the live QA box, or if you're in the room, we'll come to you with the roving mic. So I'd now like to introduce our speaker, Dr. Austen Erasmus. So Austen has worked in cities, peri-urban and rural areas over an extensive paediatric career in 3 countries. He is passionate about advocating for a collaborative and holistic approach when considering children's health. He has a registrar-led regional outreach program which provides primary health care to our rural families and teaching to their clinical staff. Austen does outreach work in Horsham and not only triage but also sets up robust management plans for these children and meets up with GPs, has roundtable discussions. As a group of doctors working in Western Victoria, we need to pool our resources to best suit our paediatric populations and share our knowledges and experiences. So thanks for joining me and welcoming Dr. Austen Erasmus.
Thanks so much for that warm welcome, Bianca, and all the lovely people that you work with that got me without any RT glitches so far. This is a talk that was put together by myself and lots of collaboration with my colleagues in Ballarat, and I think that this room attests to the fact that we're all here to help our kids. It's not just something online or a little memo that you get that helps you advocate for your kids. It's in fact networking and getting passionate speakers like we have today. Right, so my talk is on the low acuity, high prevalence pediatric referrals, and I'm going to challenge the nebulous "I think we need to work together." So what in fact am I going to cover? Why so many referrals? A shift again towards specialist and super specialist referrals. Your reasons why you have to refer to us and your workloads. What are top of the pops referrals? Who's in fact referring to us in our area in Ballarat? What do we need to do about it? What can we do about it? Let's share our resources, and we must work together. The fact that the COVID pandemic hit us hard is, I'm sure, a topic of this conversation. Just earlier you heard about COVID and post-COVID and all the referrals that we're getting, and we certainly as pediatricians are feeling this. It's not only the people running around supermarkets in Sydney for toilet paper, but in fact our kids have suffered through it. Children have become isolated at home. There have been many missed appointments, and I'm sure your practice managers, nurses that work with you, allied referrals are all exasperated at just how we fell behind in keeping up with the demand. Yes, there was telehealth, but there's so much that you can do through telehealth. Parents picked up a lot of school learning problems. They realized that their kids couldn't read, write, and spell, but they also realized that some kids needed to be in school. They just didn't want to learn at home, and they needed to be in the classroom, and yet they couldn't. And carers couldn't cope with fractious children. So this is a scene of our little puppets at home, and yes, some of them are great and they will do their work. Others can challenge us as parents. And then, of course, it's much harder to keep to the timetable and get through the syllabus when you're a parent that has 2 or 3 kids of different age levels, and you've got to keep up with that. And certainly we felt that. Don't you just love this little boy? And don't you think we can all take him home after? But of course, it's challenging, isn't it? Meltdowns can be minor, but we've seen a lot of huge emotionally dysregulated kids. And although this talk is more about the lower acuity and the first instance primary healthcare approach, certainly kids at home have placed many challenges on us as health carers. I wanted to spend a couple of minutes about the teenagers, and heard that Bianca's doing wonderful work in adolescent health. This is beautiful. This is in the moment. This is two girls sharing, touching, telling little jokes, being there and learning social interaction and skills. COVID just made them stay at home. Those that need a social life and those that needed to be with their psychologists just couldn't do that. So obviously teenagers struggled, and particularly our eating disorder and mental health care kids needed a special touch and a lot of patience with us. And obviously it can lead to that horrible picture of that isolated and unable to connect child who does feel emotionally charged and also will need mental health care. So, with a lot of passion to say, we've got many, many referrals and we need your help and you need ours. In our private practice in Ballarat, we've had over the last 6 to 9 months doubled, trebled the amount of referrals. We get up to 15 to 20 new referrals daily, 60 to 90 per week. And we're auditing them, and we're looking at our group of about 11 pediatricians who work various sessions, not every day. Our rooms also has super specialists that come up from Melbourne and do their clinics. So our kind of comfy number is 32. So if we get 32 new referrals, we can kind of divide it and we can spend enough time with our patients in front of us. We're getting 90. And there's a drawer that's getting fuller. We've got 2 lovely practice managers who spend long times on the phone explaining to parents what's going on and giving a lot of info as far as primary healthcare networks. Have you had your child's hearing checked, for example? But they're not the medical people, they're just trying to cope with the load. Our wait lists have pushed out pre-COVID. We're proud to say that, if a child had a relatively urgent problem or non-urgent, we'd see your child within 3-4 months. Now it's up to a year or 15 months. No good. That's me. And that's one of my secretaries. There's a lot of paperwork and clearly online stuff that we have to attend to every day, let alone the patient and getting the patient's blood results. We can't just leave these referrals lying around. The super specialist referral, I won't spend too much time on that, as this is more about primary care, but you're aware of the parent that wants to rush down to the children's, rush down to one of the pediatric practices and see a neurodevelopmental pediatrician who can look after their child, or they've got a blemish or a spot, it's a straightforward hemangioma, you've given the fact sheet, and yet you hear that they did somehow manage to get into the Royal Children's and see a dermatologist. It's not necessary. If you've got the fact sheets within your rooms, if you print out something and really reassure your patient, I find that often they won't come back and they will just go to the maternal child health nurse and follow through everything that you have said. The tertiary centers from complex medical patients that they are absolutely full and saturated with on a daily basis. We get many phone calls from Melbourne hospitals to take back those complex patients. Likewise, we're getting phone calls from all over Victoria. Warragul the other day, one of your patients landed up here to see somebody. Please let us all try and not lambast our colleagues that are busy enough as it is. So use your resources, use this kind of network. All right, so this is you guys. Not you physically in the room, but in Ballarat, I spoke to some of our GPs within our hospital that help us with clinics, and I phoned and saw 1 or 2 face-to-face. And these were the answers of why you have to refer so much to us. We're busy. Bulk billing clinics, super busy. School and kinder seem to pick up problems early, which is great, but they'll refer to you and say, this child has a speech delay, full stop. If that child has a stammer, a stutter, or is just a few words behind, that certainly isn't a high acuity problem. If a child, for example, previously is just stuttering at 4 years of age, maybe a bit of an anxious or an ADHD kind of child, they don't need to see a speech pathologist. That will correct. Or if you do see a speech pathologist, they'll give you online advice. They'll give you a Hannon program for a child that's a little bit behind in overall speech and language. And they'll give you a few little tips and clues, and at most one speech pathologist visit. They don't have to come and see us. Clearly, in this room, I'm sure there are a few of you that are very, very adept at rashes in childhood, which we'll come to in a minute. And if that's your forte, keep those children within your fold. Use your allied medical network. Use your psychologist that can see the child with mild anxiety before you refer. Clearly, I'm not talking about the non-verbal autistic child. I'm not talking about the child with global developmental delay. I'm talking about the low acuity cases. And then there are the parents that just want to see the pediatrician. Do they need to? No, not necessarily. And if it's well within your capability, and again, allaying their anxieties, let them stay within your fold for a while. I do get that if you live far north of Horsham in Warracknabeal and you've got a child with chronic tummy aches and you have been to your local clinics and so on, you might feel a little anxious that it's gone on a bit too long. But again, having that multidisciplinary meeting within your town, GP, maternal child health nurse, and somebody who knows the patient really well that can advocate for that mother and father or carer, it's surprising that if you take the time out and spend 5 or 10 minutes just to say, this is a straightforward mesenteric adenitis, and that's why it's going on for 6 weeks, and explain it and get a fact sheet out. It helps heaps. These were two specific ones that came out once or twice, and that's yourselves as a GP that, for example, I've got a GP in our town who does look after a lot of teenagers with migraines, but also those ones down to 6, 7, 8 years of age that can also get severe headaches and migraines. And his hassle is not diagnosing it and using all the medications that he's allowed to prescribe, but it's in fact getting that MRI in the child that won't sit still and needs to be sedated. And again, pre-COVID at Ballarat Health Services, we could get a child in within 3-4 months for that sedated MRI. It's pushed out to 9 months, a year, and there's some very fractious kids that will need an anaesthetist there. I myself, 2 or 3 years ago, hosted at the Paediatric Geelong Ballarat update a whole thing on sedation and procedural sedation. It works very, very well. But if you've got lots and lots and lots of referrals, and some of them sometimes unnecessary, then of course we all get stymied and we can't get our patients in quick enough. So whatever we can do to help each other, that's key. The doctor shopping will always continue, and in winter, obviously, if there's one of your patients that loves coming to your clinic and their child's got a fever for a couple of days, even though they know that it might be an influenza A strain, they're probably going to want to come and see you. But if they see 2 or 3 other doctors and then they come and see you and then they come and see me, they're 4 people and there's not even time for correspondence to get from one place to another. So again, spend that time and ask that carer, what are you really worried about? And sometimes it's the rash. A hand, foot and mouth rash doesn't look great, does it? I'm not worried about hand, foot and mouth. It's a very, very, very benign disease, as long as it doesn't affect the oral mucosa, and then there's a lot that you can do about that. How many of your mothers and fathers are absolutely petrified of hand, foot and mouth? So again, the education. All right, top of the pops, constipation. There's a little scenario that we often get, and that's the 9-month-old, the 15-month, the 22-month-old child that's constipated, and this is mild constipation. And there's usually the fact that they're on too much dairy. This is my experience and many of the pediatricians. Not enough water, not enough fiber. Do you know that a child from 1 year of age to 4 years of age just needs 2 serves of dairy. Why are we harping on dairy? Dairy doesn't have any fiber. So if your little poppet loves dairy, and a lot of poppets do, they'll be drinking a litre and a half of milk, or they'll have their cup in the morning, which is 1 serve, 225 mils or 250 mils, that's already 1 cup, and they might have a yogurt, this size yogurt, at school. End of story. Calcium is all they need from dairy from 1 year of age onwards. This is the child that's tending to constipation, and clearly once you've sorted the problem out, they can have a bit more dairy. But too many kids are on far too much dairy and not enough fiber. You get most fiber from fruit and veg, certainly not from dairy. All right, just to touch on mild intermittent asthma. I see excellent referrals coming through after the intermittent childhood asthmatic has gone through all the motions, has in fact gone on a preventer, and then there's more. And of course, our clinic in Ballarat has a lovely pediatrician, Shabna Rajapaksa, and she does all the skin prick tests and will be excellent for your particular client. But many kids don't need to come our way. All that they need is you and this asthma action plan, an updated one every year, and it's your choice whether you want to use the Royal Children's one, the school's one, or a particular one that you find user-friendly. I find that just 1 page or 2 pages laminated is best. The school teacher or carer that doesn't know the particular patient can quickly get it out. It's a laminated sheet and realize if there's anything specific or added anaphylaxis to something else in that child. So spending time, or your clinic nurse spending a little bit more time, seeing that they can use the preventer, reliever and spacer will go a very long way. Recurrent upper respiratory tract infections in young children, just that recurrent. If a little poppet, a babe, a little young toddler is having 6 to 12 infections this year, and in between and 3 to 5 days after that fever they're recovering, and they're on the same centile on the growth chart, that's not recurrent upper respiratory tract infection, that's normal, absolutely normal. So when you reassure the mother and show them that they're still in the green book on the same centile, that if they've lost a bit of weight, they've regained weight, that on day 3 or 5 their temperature settles, they don't always get a severe bronchopneumonia, and they're not hospitalized, that is normal. Very different for an 8 or a 10-year-old child that shouldn't be getting so many infections. Sleep issues, I think we can talk over 10 cups of coffee, but it's that routine and sleep hygiene, isn't it? And the big factors that we found, good old digital media and everything that the child is on before they go to sleep. I'm getting a bit older in the game, and I get a little bit grumpy internally when I hear, oh, but he won't turn it off, or I can't take it away. Excuse me using your kids as an example, but this is the age that they have 1 hour on any digital media when they're in primary school and 2 hours in high school, and the second hour could be a little bit of work, schoolwork, for example. Not too long ago, a little story, I'm full of stories. I had a family, 2 autistic kids, lovely parents, kids just glued to the screen and fighting. They decided as parents it had to stop. They were all unfit. They, in fact, live in Ballarat, but they came down here to Geelong, to your beachfront. They got their bicycles out, and the parents rode the bicycles with the kids. They're not allowed their digital media Monday to Friday, only on a weekend, only 1 hour. No sleep issues, or very little fighting. They're now playing Monopoly during the day, and that happened long ago. If we don't advocate for the kids, if we don't actually make a stand, if we don't say that you can actually block your phone or you can take a SIM card out, it's just going to continue. Low acuity problems at the beginning, but once they hook to it and it's a 15-year-old child that won't be so polite to his or her parent in the room while you're trying to discuss these issues, it's far down the track and you're not going to help them. Failure to thrive, If they're on the same centile, they've got Asian Filipino parents that are 5'2", and the child is on the same centiles for weight and height, it's not failure to thrive. Lots of reassurance will help. Mark Gurgis would have, I'm sure, told you about snoring and big tonsils. Won't go into that. Clearly, as a pediatrician, I would worry about a child that has sleep apnea and recurrent follicular tonsillitis. In other words, you look in the throat, there's pus, and the tonsils are bulging. The red throat, the pharyngitis, everyone's had a cold 6 times over. If it's not bacterial, it's not huge tonsils, grade 4 or 5, those big ones that look like golf balls that need to come out a bit earlier at about 4 years of age. But I'm not going to step on Mark's feet. He knows what he's talking about, and he's one of my great colleagues. Oppositional behavior in toddlers, I'm not talking about the child with huge oppositional behavior related to severe autism. I'm talking about the child that just doesn't have any manners, so to speak, is very, very pushy and hard to go out with and socialize with. Again, just your own moralistic behavior is one thing, but don't be judgmental is what I've learned in time. So listen to the story of what the parents are actually struggling with. And it might just be that they're trying to advocate for the child's got a busy life and a lot on, and they just get stuck in, but I want this and I don't want this, and they become very fussy eaters, for example. So leading by example and knowing that a child is going to respond to all those visual cues and tactile cues. Little 2, 3-year-old that just grabs things from their brother or sister or yourself, just hold on to it. You're stronger than them. But I want this. Daddy, why are you holding your earlobe? What's the magic word? Oh, please, can I have? And then let it go. Very visual, very in the moment, both parents on the same page and carrying through. How many parents do we find that one parent is trying to parent, the other one is the favorite parent of the week and comes home and buys ice cream for the child? So yes, I'm a parent. I can preach to you today, and I did go home when my kids were younger, and I'd give them about 5 minutes to make sure that their homework was done, and then maybe a bit grouchy or growly sometimes, and not lead by example. But kids are very visual, and they'll watch what you're doing as a parent. I get up in my rooms, and my staff will know that I talk too much, and I'm very animated, but I hope that some of the examples that I give to parents, to carers and people like yourselves do help. Won't go into the obesity and sedentary lifestyles, but I think we all know 2023, again going into COVID, post-COVID, the child that can't connect with his friend, teenage friend, the girl that desperately wants to share something with her teenage friends at school just couldn't, and or just sitting behind closed doors and very little that family is actually doing. So give them examples, and there are behavioral therapists that we work with that will go into a family like this when it goes from the lower acuity to the more entrenched. Common childhood rashes and birthmarks, I'm going to at the end talk a lot about fact sheets and lovely atlases that you can get, and probably if while I'm networking at tea time or lunchtime, if you wanted to grab me and let me know what you need, we can put it on your website. Everybody refers to us, everybody refers to you. We've got patients from Hamilton, we've got patients interstate, we've got patients that we look after here, but they met us when we were pediatricians in Melbourne or Warragul or Sale in Gippsland. Do they all need to come to us? Yes, it's very egotistical to kind of, yay, my patient came interstate just to see me. But with the barrage of referrals, we need to discharge our patients timeously so that we can spend enough time in the room with our patients that really need us. Let's go back to that one. I think we need to not only attend talks like this, I think we need to phone up our local allied medical people and make a date, go out for a cup of coffee, actually talk to the person in the room. A little story of mine is in Gippsland, where I did work, and that was my first port of call. I didn't know anyone in the area, so every couple of weeks I'd go to a GP practice. I'd meet 2 or 3 GPs, I'd meet the nurse, I'd have a cup of tea, I'd be shown immunisation schedules. When I got here from South Africa and Botswana, I didn't know this particular educational stands towards immunisations and where you can refer. And within a couple of weeks, and then following some patients through that were referred to me, just picking the phone up the next day and saying, I think that child is fine and can be referred back to you, or this child was sicker, that helped a lot. Working together with your local allied medical team goes a long way to getting that holistic approach. And then there are lovely, lovely GP registrars that have come through our training. One of them is in the room at the moment, and many come through our doors. Well, why do we have to nurture them? We need the workforce, but we can also teach them a lot of primary health care, and we can get them to come back to our areas. Yes, I would love you to have enough staff, but we need our own staff, and we need to share ideas. We find in regional Victoria, it's not just the person, the GP, it's their partner. Does their partner like Ballarat? So when we have advertisements of come to work to Ballarat, we talk about the lovely weather. Not, but we do talk about the scenery, the history we get, and wine and dine the partner, so that they can work in the area that they can feel comfortable, and they might be an IT specialist that can easily work in Ballarat and commute to Melbourne once a week for their business. All right, don't forget copying important people into your letters. Yes, if it's a medico-legal document, yes, if it's a CPU case and you've got one agenda and it's confidential, that's what you've got to stick to. But I find that often I'll go around students and registrars and find out they just will refer back to you as a GP, but all the people involved with that child's care is not in that letter. And then just to go on to what you can keep in your rooms, have that resource, have that post on the wall. Now at this time of the year I went to a GP practice, and they did say which age group kids can have the influenza vaccine, and already before the patient comes into the rooms they know what is available and where to get it. When I say print out, I don't mean waste paper. It is a commodity that we've got to watch, but I'm sure you're aware that when you actually print something out that's very visual and you're speaking to somebody in the room and you show them something, it actually carries a lot of weight. Look at all your websites and audit. We're doing a lot of auditing, not just at our monthly meetings, public and private. Every week, every second week, we're looking at our referrals and trying our best to get through them. We've sent regional pediatric registrars from our hospital into the community. It did take a lot of work by lovely colleagues that I work with. It's working. They get to Stawell, Ararat, Horsham, Maryborough. They work in practices like yours. They teach the nurses and do primary health care, and every second week at least one registrar will be in that area. While they're out, they have 2 supervising pediatricians, and the pediatrician on call for the week, a 3rd pediatrician, will carry a mobile phone. Not for that nebulous little call, but I've got this child who is failing to thrive. I'm worried. This is what I've done. What do you think I can do? Secondly, there is a centralized triaging model. We desperately trying to get money from the Department of Health, but we're winning. We're almost there. And that's not going to be doctor-based. We're going to be in our rooms consulting. This is probably going to be a psychologist, an OT, and a speechy, possibly with another consumer, and they look at all the referrals. Some of them will be medium and high echelon, very, very complex cases, of course, but a lot of them are that isolated speech delay. So we will be able to get them to you guys to do their hearing checks, get you as a solid GP to look after them, and then possibly only a couple of those will come our way. So watch this space. One of us will give you feedback next year, and we'll say it's not just Melbourne, it's not just Queensland, where they've done it in isolated peri-urban areas. It will be in possibly Geelong or in Ballarat that we can have a centralized triaging system. I wasn't aware of your Westvic website until Katrina, until Naomi White, until Jade, who got all my IT issues sorted out, and I went through it. It's lovely, it's wonderful. If you don't know where a dentist is in your area that can look after your little possum with teeth issues, or your grizzly teenager that will look at the dentist and the dentist will look at them and they say, if you hurt me, the child to the dentist, that kind of child, and it has happened, but you do get friendly dentists that can help, don't you? And then we're very proud of our PEDS portal. It was set up by Dave Tickell many, many years ago. Needs a bit of updating and tweaking, but it's a website and tells you who's around in Ballarat and surrounds, tells us about children at risk, tells us about Danny and Meg's regional registrar and how you actually refer. We've got to work together, guys. I love you. Please love us. Don't reinvent the wheel. Your website's excellent. I don't have to say much about it at all. It's just working. Do you guys know that there's a melanoma seminar coming up? I had malignant melanoma 25 years ago. I'm a doctor. I didn't fret that much until I got the result, but your patients don't. And although this is pediatrics, it's the parents. We want the parents to be around. Although solariums are banned, who knows which teenager, which model is in a solarium. There were kids as young as 18, 19, 22 that got malignant melanoma not too long ago. And let's share our resources. So I think I'll stop there, Bianca. Let's open it to the room first, and please just wait for the microphone.
Okay, questions from the room first.
I'll start with
online questions. We've got some good ones.
I've got an online question here that's had quite a lot of upvotes from our online audience. So I'll ask this one first. I feel like the main thing I resort to referring to PEDS for is parental concern about ASD or ADHD assessment. Any tips for how we can help with these referrals? The health pathways on this is good, but wondering what I can be doing prior to PEDS.
An excellent question, and maybe just to start right at the beginning, that 2, 3, 4-year-old child that you're worried about autism and you look at what the actual symptoms are, the most reliable one, not pathognomonic by any stretch, is the reciprocal interaction. It's not the eye contact. I've got kids with autism that have got exquisite eye contact. In fact, you get a little bit airy when they get very close to you, don't you? So I know that it's just one symptom, but if you roll a ball to a child and they take the ball and walk away and they haven't got that social interaction, that is quite a good initial step to look at. Clearly, though, once you do get the referral pathways, there are kinder visits that the field officer, for example, PINOC visits, and that actual daycare kinder visit is crucial. They will look to see how their child interacts with other kids. So I find that the referrals that we get are mostly around the 4, 5, 6 years of age, that they've already been to a daycare or kinder, and the question is, has this child got autism or not? There are field officers and there are excellent teachers in the room. As part of my work, I do observations, and if you've got an OT or a speech pathologist that will do the observation and come back, and it's not just the report, but it's what did the child actually do in the room? Was everyone moving right and this child was moving left or extremely isolated? So I find that using the people who actually work with the child and not only the history from the parents is usually very useful.
I think the other thing I'd encourage, I was in my work with young people looking at autism at the moment and looking through the autism guidelines of what can GPs do, and I think that part of the assessment is that needs assessment. So even though they might not yet have that diagnosis, in the meantime really trying to sit down with the family and identify, well, what does the young person need at this time, and while waiting for that assessment with you guys, thinking about what approaches we can put into place for those issues with some of those really important functional aspects of their life.
Yeah, excellent point. And that, I suppose, comes from once, there's anyone that's worried about the autism, it is all of those assessments and not forgetting to find out whether their child can see or hear, hearing problems, post-trauma, all of those can appear. So everyone in the allied medical field can help a lot.
Yeah, I had a kid the other day who was school refusing, and we wrote a note to say he needed to wear headphones, and I met him 3 weeks later and he's now describing he can be at school all day where he hadn't been able to before. Something really simple like that, looking at those sensory issues can really help. Is there a question from the floor?
I just want to continue the same questions about ADHD and ASD, because the perception is a lot of parents want medications, and what Bianca just suggested was great without using medications. And so it's almost like all the parents want to see the pediatrician so that they can get medications. So what's the message here? I mean, how often do we need to encourage ADHD, ASD kids to go on Ritalin or any of the stimulants, or how likely that they actually don't need the medication, they just need a lot of therapies and support and think outside of the box to help them to be better?
Excellent question, and we get the same, and obviously referrals directly from schools where the child might be in a bit of strife and they very quickly come past your rooms and come to us with just those questions. I think again, just knowledge. So, only about 4% of kids will have ADHD. And then of those, a third will need medication, another third will just need the teacher to be aware and some strategies put in place, and the last third will need medication. The other thing is, I'm sure you get referrals very early. We get kids of 3 or 4 that possibly are tearing the house apart or pulling computer wires out of their father's laptop. We really only diagnose it at 6 to 7. It doesn't mean to say at 3 years of age you can't start your functional assessments, get hearing and speech assessed, make sure that that's all in place, do those kinder visits and find out just how hyperactive or busy the ADHD child is, and reassure the mother and put a lot of other strategies in place. So the busy Dennis the Menace, but he can be redirected. He can sit and concentrate, and that's not just on his game, but that's on the floor listening to the teacher, showing an animated book and story. And then from there, give them visual cues and things to work on so that they can execute a task and actually be praised. I'm generalizing now, but I find a lot of parents want to do. They want their kid in kinder music, they want kinder gym, they're playing kick. And there's a lot of running around, but not necessarily showing at home on a quiet day of how to play a game and finish it, play a game of garden cricket, for example. So I guess I have gone in a roundabout way answering your question to say that we do get those referrals, but not every kid has ADHD. So it's the child that's not coping socially and the child that's not coping academically. Those are the kids that, despite all the functional IQ tests that they might need a cognitive test if somebody's worried about their frustration because they can't learn. Once all of those are done and you can do all those yourself, then I would refer on if you're comfortable in doing that.
Thank you. Have we got one more question from the floor?
Does anyone else have a question? No?
Anything else online, or?
I'll just have a quick look at the online. See if anything else has come through. One here.
Just quickly, I haven't been in practice a little while, I suppose, but when I was trying to get assessments last year, it was difficult to get assessments quickly. Has that changed? I mean, psychometric testing obviously is difficult, I'm sure, but is it now easier in Geelong to get testing done?
Do you mean allied health testing or paediatric?
Not allied health, I mean psychometric testing and cognitive testing and that sort of thing, yeah.
So Warnerwood does not take any more patients for assessment. Like, I work in Camperdown, so Warnerwood pediatricians have said no more referrals for ADHD or any assessments. So we have to look for other pediatricians. It's very, very hard.
Yeah, I hear your frustration, and it's similar in Ballarat, but what we've also done is every month or two we'll update, and we'll get our practice managers to phone each of the psychologists, phone the guy that does most of our cognitive assessments, and as soon as they get cancellations or postponements, or your child moves up in the list. So yes, it can take a while, but knowing how long they may take to get to your pediatrician, try your best and update. Parents don't mind, and although you don't want to infiltrate, use that word into other areas. One of my psychologist friends that does an excellent ADOS, one for those tricky patients, lives just this side of Melton. So although she's Melbourne-based, I do refer to that person for specific needs. So I guess it's again networking and trying your best and looking at your websites to see when that psychometric testing psychology referral can go through. And I've got a fact sheet that I give to the parents, and I underline which ones I think are the most important and which ones to do first.
Great, thank you. All right, well, I'm going to quickly shamelessly plug something now, if you don't mind. It's a big problem in our community, access to testing and also paediatric care, and we do need to work together. So there is a trial coming called Strengthening Care for Rural Children. It's a collaboration between MCRI, the Ballarat Paediatricians, Geelong Paediatricians, and University of Melbourne Department of General Practice, and it's going to be paediatric co-consulting out through our region. So I'm going to just say, keep an eye out for an EOI. We'll be recruiting about 9 practices across the region to participate in a co-consulting trial peds in primary care via telehealth. And also, please email me, bianca.forrester@westvicphn.com.au, if you would like to participate in a co-design session for that trial. It's going to be on the 8th of June via Zoom, and we're looking for GPs and practice nurses and managers to come co-design the model of care we'll be using for the Strengthening Care for Rural Children trial. So I'm going to hit you up and come tell me at morning tea if you want to be part of that co-design.